Yes, sir. Yes, sir.
Okay, thank you. Thank you. So, good evening to all of you. Today, I am showing a lot of short cases. Most of the cases are given to me by Dr. Samia from Calcutta. Some of them are very interesting cases. That's why I thought I will share with you those cases. Can you see my slides?
Yes, sir.
Okay, fine. Now, these are short cases only. So, first case is a edentulous elderly lady with diabetes, not a hypertensive, presented with this movement disorder of short duration. Okay, diabetic lady, not hypertensive, and the movement disorder of short duration. Look at the movement.
এইদিকে আরে ঘাড় ঘুরিও না এদিকে ডান দিকে এদিকে বাঁদিকে তাকাও বাঁদিকে তাকাও বাঁদিকে ডান দিকে আমার দিকে তাকাও
Eye movements are all normal.
এদিকে এদিকে তাকাও ওপরে তাকাও ওপরে নিচের দিকে তাকাও নিচের দিকে
She can put out the tongue.
ফাঁকা করো আঙুলগুলো ফাঁকা করে দাও লাস্টে একবার ইন্টেনশনটা করিও নিস আঙুলটা ছুঁয়ে ঠিক আছে
There is no finger nose coordination.
দিকে কিন্তু একটু ইনকোঅর্ডিনেশন আছে বাঁদিকে আছে কি না এইদিকে
So, what do you think is a likely diagnosis in this patient? Possibilities.
Edentulous dyskinesia, sir.
Yeah, exactly. That's also what I thought, edentulous dyskinesia. And this is the video from the net in the, YouTube, the case of edentulous dyskinesia. But the one which we saw was a little different from what we saw now, seeing now. Anyway, that is what I had thought initially. And she was treated. Any other thoughts? Anyone may think of any other possibility?
Drug-induced?
Yeah, drug-induced, but so rhythmic coming like that. Not the typical drug-induced dyskinesia.
Focal seizure.
ET plus also possible, sir.
Pardon?
ET plus, sir.
ET plus, okay. Focal seizures, bilateral jaw movement only. Okay, she was treated. And see the next video after treatment.
হ্যাঁ করো ঢুকে নাও এদিকে তাকাও বাঁদিকে তাকাও ডান দিকে তাকাও বাঁদিকে তাকাও
So 2 days after the treatment, this is the situation. So,
Psychogenic.
what was the treatment given?
Psychogenic.
Sir, drug-induced this thing. So, again,
Syndopa, sir.
Pardon? Syndopa. Okay.
Syndopa, sir.
Okay.
Dentures.
Then okay, for endless dyskinesia, it should disappear dentures. But the answer is none of the above. And you want to see the MRI? You want to see the MRI of the patient? I will show the MRI. That gives a little clue. Okay, let us see the clue. This is the T1 weighted sequence.
Hyperglycemic.
Yes, exactly. This hyperdensity in the T1 in the putamen. Bilateral. This is the T2. This is not finding here. That is why I'm showing the large pictures. So look at the finding now. This is a striatal hyperdensity in T1. It is seen both sides. Usually seen one side, but here it's seen both. Sometimes it can occur on both sides. And this is diabetic striatopathy. In fact, I am seeing for the first time it's a case of striatopathy for this kind of a movement. Yeah, that's a very interesting case. She totally subsided with the treatment. Any question?
Phenomenology can be called it the seizure.
No, I don't know whether we can call it seizure. Only jaw movement up and down.
Because in diabetes, commonest seizure is focal.
Yeah, but they can, correct. That part I agree with you. But it's not a focal seizure, no? We're moving both jaw up and down. Anyway,
Sir, what was the treatment given, sir? What was the treatment given?
No treatment, control of diabetes and saline. Diabetes controlled, he will become moderate. Now, the second video which I showed was after normalization of the blood sugar. Now, I'll show that next two cases are also from Dr. Samia. And these both cases are the same etiology, even the two different patients. And the duration is 3 to 5 days. Now look at the video of the patient.
মুখটা ফোলাও তো করে চোখটা জোরে চেপে বন্ধ করো মুখটা খোলো হাঁ করো
Ask him to open the mouth.
দাঁতটা দেখাও পলসিও আছে
So what did you observe in him? He has got dystonic contraction or when a blepharospasm bilaterally is asymmetrical more on the right side, as well as a facial dystonic contraction on the right side and frontalis overaction in between. So I'll show the video once again.
মুখটা ফোলাও তো করে চোখটা জোরে চেপে বন্ধ করো মুখটা খোলো হাঁ করো দাঁতটা দেখাও পলসিও আছে
Okay, I'll show the next case.
পরপর বলে যাও পরপর বলে যাও এদিকে দেখো বলো ছেলের নাম বলো
সিটি স্ক্যান হয়েছিল
মেয়ের নাম
কোথায়
কিসে এসছো বাড়ি থেকে
See the dystonic
মাঝে মাঝে
contraction
কথাটা
of the
থেমে
lower
যাচ্ছে
face
মানে
and
ইয়েটা
frontalis.
জিভটা বাইরে বার করো বাবা জিভটা বাইরে বার করো ডান দিক বাঁ দিক করো জিভটা
তাকাও এদিকে তাকাও উপরে তাকাও
The same.
কি অসুবিধা হচ্ছে
When he's asked him to open to speak again, the dystonic contraction. See the facial and recognition. So what is the diagnosis in these two cases?
Mixed,
Both are good. Pardon?
mixed syndrome.
Yeah, but make symptoms are definitely, but it's only short duration, 2-3 days duration.
Acute dystonic reaction to psychogenic drugs.
Metabolic disease.
Yeah,
Drugs.
that's it. Drug induced is one important possibility you have to keep in mind. Okay, perfectly right. Okay, so both the patient bilateral facial dystonia producing blepharospasm and lower facial contraction, and there is no history of any drug intake.
Again, diabetic, sir.
Diabetic.
Yes, both of these
Bilateral.
having uncontrolled blood sugar, recurring non-ketotic coma. Both of them had a sugar of more than 250, and both of these patients improved totally. The movement improved after a few points of saline. This also remember that for diabetic hyperosmolar coma, need not give that no anticonvulsants is required. Just control, give saline. All this involuntary movement will subside. And this is, I was not knowing this kind of thing can occur with the diabetic ketoacidosis. So in the literature, it is mentioned hyperglycemic hyperosmolar syndrome presents unique craniofacial involuntary movements. I will show a video from the literature, again, Neurology, exactly something similar to our patient. See, this is from the literature. It's got a facial dystonic contraction. Neck goes into a distal extension. See the frontalis contraction coming in between. Orofacial lip movements. Choriodystonic movements.
குடிக்கும்போது என்ன ஆகுது காமிச்சிருங்க
He speaks, it comes. That's the movement going. Neck goes into extension. So the lesson is that any kind of involuntary movement in diabetic, consider this eminently treatable disease, especially when the disease is of short duration. That is a lesson we have learned now. Okay, any questions?
A few months back, you had shown two cases of these similar facial movements in diabetic patient. You had called the term facial asterixis, sir.
Correct,
So,
yeah.
can we call
Yeah.
these two movements also called kind of facial asterixis?
Yeah, but usually the term axis is a negative myoclonus in metabolic toxicants. So I don't know whether we can call this as facial axis. This looks like very much like a choreodystonic movement, no? Before spasm. It's a moment of eyelids are blinking, jaw is opening, lower facial goes into contraction. Phenomenologically, more like a dystonia, and with episodic, some choric movements also in between. Whether we
In
can
the
call
second
facial.
patient, sir, it was precipitated on action, on speaking, or like a
Yeah,
tasks
yeah.
specific dystonia in that patient.
Exactly, yeah. You are speaking, it comes. Literature patient, the one which have brought in the literature also, the patient is asked to speak, then the link then goes into backward dystonic posturing. So
Yes.
all this is to get your diabetes.
Sir, do we have to do MRI in all the cases?
No, not at all. Because the first case we had just read because we did not know, it was not a thing which you usually see in diabetes. That is the MRI was done. Okay, shall I go to the next case? Okay.
Yes, sir.
Yeah, this is another case, again from Samia. This was case of a neuro-Wilson disease in hepatic encephalopathy. They're all short cases. And patient is in coma. It's a girl. Look at the eye movement. What do you think about the eye movement? What do you think the patient is saying? What is eye movement called?
Windshield wiper eyes, sir.
This is not windshield. Okay, you can call it that way, but it's only one side, no? Okay, I'll come to that. I'll show another two patients in coma. This is my patient, which I had seen earlier. Same slow movements going from one to other side. Here it is from right to left. Okay, this is another patient. This is not my patient. Okay, what is the diagnosis?
Ping pong case seen in
Yeah, exactly. This is ping pong phase. That is called the roving eye movements. It usually, see, the lateral two ones are going to either side, to the right as well as to the left side. Okay, if you find that one, it indicates usually a bihemispheral dysfunction. That tells you the brainstem is intact. That is why eyes are moving like that. There should be bihemispheral damage, either metabolic or usually it is hypoxic damage, but can be due to metabolic causes also. Now, look, compared to this one, look at the first one. It is moving only to one side, not to the left. See, to the right.
Dystonia, sir.
No, it's not dystonia. It's again roving a slow movement to and fro, but only does not go to the left side, only come up to the midline.
Can be seizures ongoing.
No, it's not the same thing. The same phenomena, because there is no fast component here, only slow component rowing. Only thing rowing is only stopping at midline. It's not going to the other side. So the pathophysiology is same only. So this is called unilateral roving eye movements. Eye movements only to one side. The problem is the cause is same. It's a hemispherical damage, but asymmetrical damage. The second and third case, bilateral roving eye movements, are called the ping pong case. Now, a few words about this thing from the literature. Unilateral roving eye movements, or a form of bilateral roving eye movements occurring only in one eye, are a sign of cortical dysfunction or brain damage typically involving supranuclear pathways. Unlike the symmetrical roving eye movements, a unilateral presentation may indicate a more focal cerebral injury and be less indicative of a widespread brain damage normally associated with the bilateral one, ping pong case. These movements can occur in conditions like stroke, metabolic coma like hypoglycemia, and the presence suggests that the brainstem is functioning normally. Okay, that is the thing. So, any questions? Okay, so I have not seen a unilateral roving movement before, but this is a roving eye movement. More common is a bilateral roving eye movements.
So why is it happening in Wilson, sir? Because of encephalopathy.
No, not for the Wilson. This is only part of the hepatic encephalopathy, not due to the Wilson's per se. Any bihemispherical dysfunction, sparing the brainstem can produce this thing. Usual situation is significant damage as in hypoxic cerebral damage. Not due to the Wilson. This patient had Wilson disease, but the cause was the hepatic encephalopathy.
So what is the prognosis like?
Usually, if you find these things, prognosis is poor. Because the commonest condition is bihemispherical hypoxic damage, I told you. So prognosis is poor. But sometimes it's also described in metabolic encephalopathy. So that possibility has to be ruled out before diagnosing hypoxic damage.
So this patient has succumbed to the disease 3 days after I took the video of a severe GI bleeding.
Okay. Unfortunately, yeah.
Prognosis was very poor even when I saw the patient.
Okay. Thank you, Samir. Thank you.
So do we have to suspect any seizure? Do we have to do EEG or something? When you see
No,
these
this
eye
can,
movements.
no, in the case, in a comatose patient, you find a nystagmus-like movement, it is seizure. Because no nystagmus can occur during in a coma. Because nystagmus require a fast component. So if you find a fast component, it is like you have to think of a seizure. Okay. In a nystagmus, the fast component is the corrective component. So the simple dictum is something like a fast movement occurring in the eye, whether it's irregular or regular, consider the possibility of a strongly a seizure phenomenon. But this kind of a slow movement like that, it's not suggestive of a seizure.
Yes.
Okay, this is another case. 68-year-old farmer who suffered a Pontine hemorrhage, presented with generalized dystonia and stiffness with some eye findings and facial findings 4 months after recovery. This mainly to find out to explain for the physical findings. This is the video of the patient.
ডান দিকে তাকানোর চেষ্টা করো,
She's
বাঁ দিকে তাকানোর চেষ্টা করো,
left and right, up and down.
ডান দিকে
You
তাকানোর
cannot do
চেষ্টা
that.
করো, উপরে তাকানোর চেষ্টা করো, উপরে উপরে উপরে,
You cannot look
নিচে
up and
নিচে
down.
নিচে তাকানোর
But
চেষ্টা
he has
করো,
got a spontaneous eye movement, as you can see there.
দাঁতটা দেখাও, জিভটা বার করো,
Right facial palsy.
বড় করে। আচ্ছা, দুটো হাত সোজা করো তো, এরকম
It's
করে
also
দুটো
got
হাত
some
সোজা করো।
dystonic posturing in the right upper limb with some tremor there on the right upper
ঠিক
limb.
আছে, ছেড়ে দাও, নিচে নামাও। এবার আমি যখন বলবো চোখটা বন্ধ করবে, আমি যখন বলবো চোখটা খুলবে। চোখটা বন্ধ করো, দুটো চোখই বন্ধ করো।
You can see the vertical eye movement
খোলো।
seen very clearly now.
আবার বন্ধ করো, আবার খোলো।
Okay. You want to see the video once again?
Yes, sir.
Yes,
Yeah.
sir.
Yeah, there is sort of finding there. Okay. So
ডান দিকে তাকানোর চেষ্টা করো,
this
বাঁ দিকে তাকানোর চেষ্টা করো,
is up and down vertical.
ডান দিকে তাকানোর চেষ্টা করো, উপরে তাকানোর চেষ্টা করো, উপরে উপরে
Looking
উপরে,
up, looking
নিচে
down.
নিচে নিচে
Not
তাকানোর
possible.
চেষ্টা করো,
Looking to the sides, not possible.
দাঁতটা দেখাও, জিভটা বার করো, বড় করে। আচ্ছা, দুটো হাত সোজা করো তো, এরকম করে দুটো হাত সোজা করো। ঠিক আছে,
Dystonia,
ছেড়ে দাও,
tenderness to
নিচে
the right
নামাও।
upper limb. And
এবার আমি যখন বলবো চোখটা বন্ধ করবে, আমি যখন বলবো
Close the
চোখটা
eyes.
খুলবে, চোখটা বন্ধ করো, দুটো চোখই বন্ধ করো। আচ্ছা, খোলো, আবার বন্ধ করো, আবার খোলো।
Okay. So what are the findings in this patient? What is the type of nystagmus you observed? It's a vertical pendular nystagmus. There is no fast component or slow, only slow component. It's moving up and down like a pendulum. So it's a vertical pendular nystagmus. It's got acquired
ডান দিকে
regularly.
তাকানোর চেষ্টা
Eye
করো,
movement. So it's a vertical
বাঁদিকে
pendular
তাকানোর চেষ্টা করো,
nystagmus, which you see there. Okay, that is one.
ডান দিকে তাকানোর চেষ্টা
Second
করো,
thing what you observed was that
ডান
he's
দিকে
got a
তাকানোর
gaze
চেষ্টা
palsy,
করো,
unable to move the eyes in all
বাঁদিকে তাকানোর
directions,
চেষ্টা
meaning
করো,
vertical and lateral gaze palsy.
ডান দিকে তাকানোর
Third
চেষ্টা
thing, he has
করো,
got the right element
উপরে
facial
তাকানোর
palsy.
চেষ্টা করো, উপরে
And
উপরে
these
উপরে,
are the things which you
নিচে
observe.
নিচে,
Then some
নিচে তাকানোর চেষ্টা
dystonic
করো।
tremulous hand of the right upper limb. So bilateral vertical gaze palsy, bilateral lateral and vertical gaze palsy, acquired pendular nystagmus vertical, right element facial palsy, abnormal position of the right upper limb. So this is the CT of the patient. Showed a hemorrhage in the pons, more towards the left side. Okay, now I wanted to explain each of these symptomatology based on this patient's finding. This is bilateral, lateral and vertical gaze palsy. Yes. A Pontine lesion usually will not produce a vertical gaze palsy, only lateral gaze palsy. Bilateral lateral gaze palsy can occur either due to the bilateral PPRF involvement or the abducent nuclear complex involvement. Okay, vertical palsy will not occur with a classically in a midbrain as a Pontine lesion, but it is rarely described in Pontine lesion also, rarely, not very common. Case reports are there. And acquired pendular nystagmus due to what? This we have discussed many times.
Central tegmental tract. Central
Yeah,
tegmental tract.
segmental tract. Very good. Then element fish, okay. Abnormal posturing of the right upper limb with tremor.
Yes, right now.
Yeah, due to what?
Is it because the dentator rubrothalamus cortical, sir?
Yeah, correct. That should be the red nucleus involvement. Okay. Yeah, that should be the opposite side, left side. So these are the findings this patient. So he's got an extension also more towards the left side. But element facial palsy on the right side. Okay. So main trend is on the left side, but element palsy has come to the right side. That is why it is affected the right facial palsy also. Okay, so bilateral vertical in a bilateral lateral and gaze palsy due to Pontine midbrain lesion. That is central tegmental tract lesion, the Glenn-Muller triangle, right element facial palsy due to the contracted nucleus. Now, can a Pontine lesion cause vertical gaze palsy? It is not usually seen, but rarely. I also seen one case like that, where producing vertical gaze palsy due to a Pontine lesion. I was not knowing the explanation, but literature says it can occur rarely. See, ascending pathways from paramedian Pontine reticular formation to the rostral interstitial nucleus of Cajal, nucleus of medial nodular fasciculus have been demonstrated, and by that condition, the monkey have been reported to impair vertical saccades. Selective rostral Pontine lesions in the monkey also produce horizontal saccadic palsy only, whereas lesions in the caudal pons produce both horizontal and vertical palsy. Now, how this is possible, they postulated some involvement of the omnipost neurons and all, but that explanation does not appear to be logical. So I don't think that explanation will hold true. But whatever it is, it can occur rarely. So clinical reports of Pontine lesion in humans inconsistently show abnormalities with voluntary vertical gaze despite caudal involvement. This is also another article. A small dorsal pontine infarction presenting total gaze palsy, including vertical circuits and pursuit. So if lesion is there, don't think that it cannot occur. It need to be always midbrain to be involved, but usually midbrain has to be involved. That is a classical thing. Okay, any questions?
Why was the right facial palsy, sir?
Because the lesion is extending onto the right side of the pons also.
Okay.
It's bilaterally there. It's not only confined left side.
So in left facial also should have been there, no, sir?
Yeah, because it's got a bilateral gaze palsy lateral. So it has to be bilateral only. Unilateral pontine lesion will not produce a bilateral gaze palsy. Lesion is
facial
bilateral.
palsy.
That's maybe asymmetrically gone to that side. That's
So any syndrome?
I don't know. My personal advice, don't by heart syndromes. Because it all depends upon where exactly the lesion is. A hemorrhage can go that way, this way, and it can involve structures depending upon where the lesion is. So I think better not to think about the symptoms. But the structure is there, everything this will produce. That is more important. Okay, shall I? Yeah, please.
Pupil, sir, will be small size, sir.
In this page, I don't know. This is not my case. Usually, when pupil to be affected, it has to be in the midbrain. The so-called pinpoint pupil is in acute pontine hemorrhage. Not a usual pontine lesion, the pupil will not be affected that way.
Okay, sir.
And the posterior. Yeah. Please ask.
Tremors, sir. This is there any will it subside after some time or it will continue to be?
No, most of the time it can continue up when it is 2-3 things about rubral tremor. When there is lesion on the red nucleus or its connection, the red tremor may not appear immediately. It can appear weeks or months later. And it once appears, it usually is persistent. And some of the rubral tremor do respond to levodopa. Surprisingly do respond to levodopa. So most of them do not respond, but some of them do respond to levodopa. But so for whatever case I have seen, it never subsided. Okay. Right. This 14-year-old boy with high myopia presented with head tilt held to one side, held it and side to by side subtle neck movements, especially without spectacles. See the video of the patient. I'll show the video. This again. This is the eye movement.
এবার এদিকে একবার আরে পিড়ি আর একটু র্যাপিড হবে ঠিক নো আরে পিড়ি
Okay. Now let us see the next part of the video. Same patient.
বাঁদিকে তাকা ওপরে তাকা
Looking up.
নিচে তাকা ওপরে তাকা
Do the vertical move.
নিচে
Looking up,
তাকা
eyes are diverging. Looking down, it's converging.
ডান দিকে তাকা
Right.
বাঁদিকে তাকা
Left.
ওপরে তাকা
Up.
নিচে তাকা
Down.
নিচে তাকা আচ্ছা এবার দূরে তাকা
So you want to see the video once again, or is it enough?
It's a congenital.
Yeah, tell me. Yeah.
So the nystagmus was horizontal even on vertical gaze.
Correct, perfectly. So it's clearly a congenital pendular nystagmus. And remember that a congenital pendular nystagmus need not always be pendular. On extremes of case or eccentric case, they can assume a jerk quality as in this patient. That is not against a congenital nystagmus. But what is ocular movement like?
ওপরে তাকা নিচে তাকা, ওপরে তাকা, নিচে তাকা, ডান দিকে তাকা, বাঁ দিকে তাকা, ওপরে তাকা, নিচে তাকা, নিচে তাকা। আচ্ছা, এবার দূরে তাকা।
What do you think about that thing?
Convergent spasm, sir.
B-type
Convergence.
isotropia, sir.
It's actually, it
When
is
he looks
actually,
down,
yeah, it looks down, it gets isotropic. It becomes addictive.
yes, both are.
Right. Right. But if patient is not asked to do any convergence, it's spontaneously coming in convergence, looking down.
B-type isotropia.
Yeah, correct, exactly. This is called it's in a B type of a congenital strabismus. I'll tell you about that thing. This is very, very common when you observe the patient with these things. When you find this thing, you can be very certain this is a congenital, this kind of an abnormality. So nystagmus and vocal abnormality, it's a congenital horizontal pendulum nystagmus, already told. And this is called the V pattern congenital strabismus. I'll tell you this pattern. See, this is the one which you observe. Looking up, the eyes are diverging. Looking down, the eyes are converging. So there are very many patterns. The common one is V. Second is the A pattern. The other is X pattern. Then it can be Y pattern. So I'll tell you the various patterns. The most one is so vertically incompetent pattern of strabismus used to describe the type of strabismus wherein the amount of horizontal deviation changes during the escalation of eye from up gaze to down gaze. It is a common association of many types of strabismus, especially infantile esotropia and intermittent exotropia. Several patterns have been described for the type of vertical incompetence observed, example A or V pattern, depending upon the relative increase or decrease in the horizontal deviation during the vertical eye movement. So for example, V pattern is the common one, where on looking up, the eyes diverge, looking down, the eyes become isotropic or become adducted. When the eye converges as the eyes moves from up to downward, it is a V pattern, become close together. The V pattern exotropia, the deviation is more in the up gaze than the down gaze. This is the most common type pattern of strabismus. Other is A pattern, when the eyes converge as the eyes moves from down upward, like A, the peak of the A. Therefore, in A pattern esotropia, the deviation is more in the up gaze than the down gaze. It becomes isotropic when you look upward. That is why it becomes A pattern. There is a Y pattern. This is considered a subtype of A pattern, wherein the horizontal deviation remains stable from midline down gaze to the primary position. It is same, not going to either direction. But on looking up, it diverges. Then the X pattern is on looking up and looking down, it diverges, like an X. From primary upward diverge, downward also diverges. As the name implies, here is the relative divergence of both eyes in both up gaze and down gaze. This is a shape of tight lateral rectus that may be seen in long-standing exodeviation of type 1 syndrome. Overaction of both superior and inferior oblique also been implicated in some cases. So that's about the story. So the only idea is that, so when you find such an abnormality, don't think there is a really wrong with the patient. It can only be can be seen in many of the infantile strabismus syndromes.
So can we
Okay.
say this is spasmus nutans?
Spasmus nutans is entirely different. Spasmus nutans is a condition usually seen in children from the age of 6 months to 3 months to up to 1.5 to 18 months. They've got three characteristic features of spasmus nutans. One, that is asymmetrical nystagmus. It's a fine nystagmus, usually a vertical, jelly-like nystagmus. And that is one point. Second, they have got associated head noding. And they have got a torticollis. Three things: head noding, or a tremor, torticollis, and a fine asymmetrical, usually vertical. Sometimes it can be other direction also, usually vertical nystagmus. And most of them self-limiting, disappears during by the age of 18 months. However, nowadays we found that this kind of a so-called spasmus nutans are not always benign. Some of them can have paracellular tumors or third ventricular tumors, optic-chiasmal compressions can also cause such spasmus mutants. If you get so-called spasmus mutants, always you have to investigate before calling a typical spasmus mutants. Somebody the nystagmus very difficult to see. It was a very fine nystagmus, asymmetric. So simply jelly like a jelly, it moves like that.
Thank you.
Now, what is this abnormality? These are all Samia's cases. This is also an interesting case. Look at the abnormality.
উপরের দিকে তাকাও, নিচের দিকে তাকাও, উপরের দিকে তাকাও, নিচের দিকে, সাইড বাঁ দিকে তাকাও, ডান দিকে তাকাও, বাঁ দিকে, ডান দিকে, বাঁ দিকে, উপরের দিকে তাকাও, নিচের দিকে তাকাও, এটা বন্ধ।
Okay. Tell one more part of the video. The relevant part, I'll show the video once again. Okay, moments for all now. Okay, any thought? What do you think about the abnormal eye movement?
Ocular flutter, sir.
Yeah, this is a typical ocular flutter. Why? Because there is no intersaccadic interval. Okay. So what is the likely etiology in this patient? Usually ocular flutter you can see in post-infective cases or a part of it's a younger brother of opsoclonus myoclonus. It's actually a problem in the relation of the omnipost neurons where there is lack of inhibition of the burst cells. So any condition can produce that thing affecting the omnipost neurons. Maybe post-infective that is common, or maybe paraneoplastic syndrome as a case of opsoclonus myoclonus. So these are the usual causes. So in this patient, this ocular flutter and history of the patients I will give you. He is asymptomatic, came in for non-specific headache. He had a history of infantile epilepsy for which he received phenytoin carbamazepine for 10 years, but is currently not on any drug for the last 3 years. This is a story given to me by Dr. Samia. Any pardon?
Video, sir. Video. Once more, sir.
Okay. I'll see that. That's in fact, I anticipated that question. That's we already recorded it again. The same video, the 11 points I'm seeing, showing against again.
উপরের দিকে তাকাও, নিচের দিকে তাকাও, উপরের দিকে তাকাও, নিচের দিকে, সাইড বাঁ দিকে তাকাও, ডান দিকে তাকাও, বাঁ দিকে, ডান দিকে, বাঁ দিকে, উপরের দিকে তাকাও, নিচের দিকে তাকাও, এটা বন্ধ।
Okay, any thoughts? Post-infective demyelination.
Drug-induced.
No Stephen drug intake. He was not in drugs. Previously, he was treated for epilepsy. Now, I'll show you 2-3 important points. Look at the video once again. His eyes goes into convergence off and down. And the movement velocity of this is not same all throughout. Let us see. In between dialysis blephorospasm also. He's voluntarily converging the eyes. Let's see this one. I will show this part of the video. Let us see this part of the video once. Look at it very carefully. Sometimes he'll converge his eyes. That's why they induce movements. Usually the voluntary nystagmus, they try to crank their virgin system to remove that. Look at the disconjugation appearing at time. See that one? That's the time when he's converging the eyes. You see this one? He's trying to voluntarily blink and to induce that thing. See, there is no convergence now. Convergence to the left eye. That was the clue. Suspected psychogenic ocular flutter. I have seen some other persons can mimic, they crank their system adduct their eyes and then induce convergence to produce fluttering like movements. But he was, even without that severe convergence, he is able to do that ocular flutter like this.
You can also do, you have also demonstrated.
Exactly. Sometime I have demonstrated by this thing, I could do that. With convergence system, I can make this flutter-like movements to the eyeball. Sir, so that is the clue that some person can do like that. Now you may think it cannot, no? Go to the literature. There is a lot of functional saccadic oscillations in ocular crisis. But unfortunately, I couldn't do the video from the literature. So in case of ocular crisis, conjugate ocular movements are more sustained. In psychogenic eye flutter, the ability to provoke such movements only able to put 8% of the healthy controls. So that is regarding that thing. Any questions?
Why is it that this occurs episodically? Like sometimes it may not be there, no?
Yeah, correct. That ocular flutter also, it may not be there all the time coming. It only episodically only. Even organic ocular flutter. It may not
That
be
is why, because anyway, that omnipus neurons anyway is defective. So it should be like lack of inhibition of this thing it is a consistent thing.
Yeah.
But why it is?
Your question is very logical, but difficult to answer. But like all involuntary movements, they are not even though whatever be the pathology, pathophysiology, they occurs episodically only, It is not consistently coming all the time. It's difficult to explain why it is occurring all the way, a static pathology occurring like that.
But this opsoclonus is almost always, I mean, it is unlike ocular flutter.
No, opsoclonus also occurs episodically.
Also is there, okay.
Yeah, it will come like that, disappear. Come like that, disappears like that. Sometimes
but they say
will...
in sleep and all opsoclonus we can see that eyes will be some, like if you see that patient opsoclonus, the eyes will be moving or something. It is present in the sleep also like that, opsoclonus.
No, usually, and I do not know about whether it will persist during sleep or not. Usually occurs when the fixation, when the patient is asked to fix, then only this circadian system is made to work. See, normally the omnipus neurons is keeping the eyes always inhibited, eye movement inhibited. When you want to make a saccade only, this inhibition takes off. Okay,
Yes,
so logically, when whatever the situation with inhibition is taken off, you can have during sleep also. What you said is correct. You can also have it in sleep also. But I had not read about occurring in sleep. I have not read, frankly. But theoretically, you are right, because the mechanism can suggest that way. But one thing is certain: this is always episodic. It need not be all the time. Another important thing is that suppose you do not find ocular flutter opsoclonus, If you make them do refixation saccade, has to move from one place to another, look at one point to another point. At that time, this involuntary movement will appear. That is an easy method to elicit an ocular flutter, which is not present all the time, appear. Same with obstructionis. So obviously, it's triggered by some saccadic movement that will be more prominent. Extreme form, it occurs at distance. Okay, now Samia's case is over. Now I'm going to show my cases, 3 cases. I'm show 3 short cases, all with the same complaint of long duration spanning 6 years to 20 years. In fact, this abnormality has seen observed very for a long period of time, and I was not knowing what to call these conditions. Let us see. The videos which are shown are the ones after treatment, because these patients I have seen long back. At that time, I could not take a video or anything. So they have been under my follow-up years and years. So I thought I will video some of them and to show this abnormality. All are simple cases of it. So all of them had shown remarkable improvement with treatment. Now, this is a story of a 60-year-old man. I had seen him 10 years back with his severe tremulous movement of his fingers causing difficulty in eating. He was put on medication and the disease was relatively under good control. He came for follow-up after 2 years for another complaint. No walking difficulty at any time. He had a positive family history of tremor in his father. Look at this hand movement.
കുറച്ച് അടുത്തോട്ടുണ്ട് മൂക്കിൻ്റെ അടുത്തോട്ടുണ്ട് അവിടെ നിർത്തിക്കേ അത് നിർത്തി.
In fact, this is much larger than earlier. Now it's much better with treatment.
ഇത് തൊട്ടുകൊണ്ടേ ഇരിക്കണം.
His gait is normal, rhombus is negative. Initially, he had walking difficulty also due to tremors on the lower limb, which is not there now with treatment. Okay, what do you think about the involuntary movement he is having? Semiologically, what is it? Or phenomenology of this movement?
Essential tremor.
Tremor, okay.
There is also a jerky component.
Exactly. This is not a tremor. See, this is mimicking a tremor, but actually not a tremor. Because he's a myoclonus, mini myoclonus. I will show that video once again. The particular the hand movement now. See, jerky component is there. See that? See that? It's not a rhythmic sinusoid movement is not there. It's a jerky component. Okay. So another patient, the same problem of 5 years duration. This lady, superficially it looks like a tremor only, but actually if you look very closely, they are not tremor.
ഇനി നേരത്തെ കാണിച്ച പോലെ കൊണ്ടുപോകാം. ഞെട്ടിക്കരുത്, മുട്ടിക്കുന്ന പോലെ പിടിച്ചോണ്ടിരിക്കുക, ഞെട്ടിക്കോട്ടെ, ഞെട്ടെനിക്ക് കാണാൻ വേണ്ടിയിട്ടാണ്.
See that one? It's not rhythmic. It is irregular and jerky. Same patient. It is present, not present at rest, only during action.
രണ്ട് കൈ കൊണ്ട് കൊണ്ടുവന്നേ, നേരത്തെ കൊണ്ടുവന്നതിന് കൊണ്ടുപോകാൻ. ആ തൊട്ടുകൊണ്ട്
Her tremors was also much better treatment. She was not able to do her household activity before. Third similar patient, man aged 70 years, was untreated 16 years. He also came with similar tremor with inability to eat from the plate or drink from a cup. He also gave history of seizures. Look at this man now.
Fame, sir.
Pardon?
Fame, sir. Fame. Oh,
X,
sorry,
X,
familial
yes,
action
yes,
myoclonus, epilepsy, famous.
right, exactly. So some of them do not have epilepsy. See, in my patients, only few had epilepsy, not all of them. And this was and remained for a long period of time without any other neurological deficit. See, it's coming in intentional myoclonus. I did not know what the diagnosis at that time. So I used to write it as intentional myoclonus, benign intentional myoclonus. That was my diagnosis which I written in my OPD card and all. Okay, so the what is the treatment given in this patient? All of them improved.
Clonazepam.
Clonazepam. So I have given encouraged sodium valproate and clonazepam. And try to reduce encouraged clonazepam, it appeared again. The treatment is same as just like the myoclonus, not the treatment of the tremor. Tremor we propranolol and this thing like that, tremor, this is definitely different. So as the doctor was telling, this familial adult myoclonic epilepsy called FAME. It's an autosomal dominant condition characterized by cortical tremor. In fact, I do not know whether we can, they call it cortical tremor, but it's not be a cortical tremor. But if it's not fit with the definition of tremor is always rhythmic and sinusoid. This is not rhythmic, now can you call it tremor? But in all literature, they cortical tremor. Anyway, this is what their term given. Cortical tremor and myoclonus usually manifesting within the second decade of life, and infrequent seizures developing in the third and fourth decade. Cortical tremor is the core feature of FAME, which is being considered as a part of spectrum of cortical myoclonus. How can this spectrum of cortical myoclonus I don't?
Can we call it a tremor myoclonus?
I don't know. Tremor myoclonus, tremor is there, myoclonus, that can agree. Tremor and myoclonus. But you cannot entirely call it a cortical tremor. That's an objection. It's actually myoclonus. Its myoclonus is so frequent, so mini polymyoclonus also looks like a tremor only, but there are also myoclonus. So these are the genes associated with it. Let's skip the genes and all. So this is again from literature. Cortical tremor is a rhythmic involuntary shaking of hands that's caused by abnormal activity to the brain. That's okay. It's considered a rhythmic variant within the broader spectrum of cortical myoclonus, with both conditions stemming from the hyperexcitability of the cortex and presenting with short EMG bursts. Cortical tremor, which can be disabling managed in cortical myoclonus, is treated with medical like levetiracetam, valproic acid, and clonazepam. I think this I will skip. What is cortical myoclonus and cortical tremor? This is the difference between the two. Cortical tremor is a rhythmic version of the cortical myoclonus, and both originate from the abnormal hyperexcitability. While tremor is rhythmic and jerky, myoclonus is more generalized term for the involuntary twitching. Anyway, that again is not a good statement. So the same condition which already told. One of the most prominent examples of familial cortical myoclonic tremor and epilepsy, a genetic condition characterized with triad of cortical tremor, distal myoclonic jerks, and epileptic seizures. This is again from literature. Just like our patients, cortical tremor. This patient also had effect on the lower limb. One of my patients had affected the lower limb also. This is another patient again from Neurology journal.
My finger and touch your nose and go back and forth.
Anyway, that's the story. So any questions in that?
Sir, how to distinguish this condition from dystonic tremor and mini polymyoclonus?
Yeah. In fact, they're all myoclonus only. In dystonia, you can have tremor. Dystonia, you can associate with myoclonus. Mini polymyoclonus. It's all myoclonus, mini. Okay, when they are, because so frequently, it looks like a tremor. So my condition is all of them are only tremor, myoclonus only.
Sir, in a case of dystonic tremor, would we prescribe valproate because it may worsen the dystonia or the Parkinsonism?
Yeah. No. The thing is, dystonic tremor is the or dystonic myoclonus both accompany the dystonia. So that's what the difference between the dystonic tremor and the other tremor, the tremor which we are talking about. If there is dystonia is there, it is a part of the dystonic syndrome. Because suppose spasmoid cortical is a writer's cramp, even primary writing tremor, so-called primary writing tremor, is actually many of them do have an associated dystonic component.
Okay.
Yeah. So when dystonia is there, you say it's a dystonic tremor. In such a case, some dystonia may be masked also. It may not be, dystonia may not be very obvious unless you do electrophysiological studies showing a co-contraction of the agonist and antagonist.
Surface EMG.
Usually need. So what in the case of tremor is alternating contractions, no? Whereas in the case of dystonia, there is agonist and antagonist contracts too simultaneous. If you want a wrist bone, extensions and flexors both will produce simultaneous EEG contractions.
So we do the conventional needle EMG only for this, or surface EMG followed by needle EMG?
I don't know, because surface EEG is an AMG is enough probably, but I don't know, more useful will be definitely will be a needle EMG.
Okay.
Okay.
So do we need to do EEG for these patients? Do they show any spikes?
No, I have not done EEG in none of these patients because I never thought it's a part of epileptic syndrome. It's only a myoclon, bilaterally present, like that continuously. How can the seizure occur like that? Anyway, they say this due to hyperexcitability. I do not know whether literature say there is EEG abnormality in such patients also. That I have to look up. They demonstrate hyperexcitability.
Okay.
So we can call it a kind of a seizure also. But even difficult to believe that both sides simultaneously like that seizure activity coming, not present at rest. No, this story of a 42-year-old man, history of RTA with polytrauma 3 months back. He recovered. On recovery, he was noticed a weakness of both the lower limbs with retention of urine. He also complained of burning pain in the right lower limb. So, in fact, I brought the case not for the localization of the spinal cord problem, but to show something else. But this is the initial part of the patient. His upper limbs were normal and ribs are normal. Then coming to the lower limb, he has got wasting of the right lower limb. His flexion was more, all muscles were weak on the right side. Left side hip abduction was weak. That is 0 power on the right side. Left side dorsiflexion normal. Plantar flexion weak on the right side. That is normal power. Abduction, adduction weak on the right side. Reflexes normal in the upper limb, absent in the lower limb. Random mute. He had pain loss somewhere around up to the mid leg on the right side. Yeah, there he is able to feel. Able to feel in the thigh. Left side is able to feel all throughout. He is able to feel on the left side. Upper limb vibration sense is normal. Vibration is impaired at both lower limb, both feet, and joint sensors are impaired. Okay, so that's so he had wasting of both thighs and calves, mainly on the right side. Right up lower limb, weakness of all muscles of the right lower limb, grade 2 proximally, grade 0 to 1 distally. Left lower limb weakness in left hip abduction and dorsiflexion plantar pressure in the left ankle. Mild weakness. Both knee jacks and knee jacks absent. Sensation impaired pain below L3 on the right side. Impaired JPS vibration of both feet. So MRI showed a traumatic injury to the spinal cord from lower down up to the mid dorsal region. Okay, so that's the story. That's no problem in localization. Now, 3 weeks later, the patient had episodes of jerky movements of the trunk and lower limb lasting for 2 to 3 minutes. And this video was, this movement starts from the abdomen and spread to the legs. These movements are decreased by flexing the legs by the bystander. This is the video of the patient. See, look at the truncal movements. Jerky movements of the trunk. This is the abdominal muscle contraction appearing. So what is the diagnosis now? What are these
Propriospinal myoclonus.
Pardon?
Diaphragmatic myoclonus.
Spinal
Okay.
myoclonus.
Spinal myoclonus. Yeah, it's spreading from the trunk to the lower limb. That's what it's just start, then come to the lower limb. And it decreases when this most likely propriospinal myoclonus. Now I'll show some other myoclonus also, truncal myoclonus later on. So it was first described by Brown in 1991. It originated from a spinal generator, more commonly at the thoracic out level, that recruits the axial muscles up and down in a bidirectional fashion via long polysynaptic propriospinal pathways. It occurs more commonly in middle-aged men, characterized by axial flexion more than extension jerks involving the neck, trunk, knees, and hips, and could occur at a frequency of 1 to 6 Hz. Usually occurs spontaneously, typically in a lying down position, and can be stimulus sensitive to tapping the abdomen or eliciting tendon jerks. It may also occur during the wake sleep transition. I think I'll skip that thing. EMG will skip. The 3 types of propriospinal myoclonus described. One is idiopathic, second is symptomatic and functional. Approximately 80% cases remain idiopathic. Symptomatic cases secondary to spinal cord trauma, as in our case, infection, tumor, or myelitis. Recently, an increasing number of cases with functional etiology have been reported. So these patients are treated with the treated usual myoclonic treatment. It totally improved. All these movements disappeared after 2 to 3 weeks time. He started walking normally. Now, what about these movements? Let us see this child. This video was also sent by on Neurology to me. I forgot the name. This child is sleeping. Look at the trunk. Rhythmic, sometimes myoclonic check, sometimes in between corresponding one episode or 2 episodes. This is another child again occurring in the trunk. Trunk get flexed like that. But unlike a propriospinal, this is not spreading up and down, only confined to the trunk. Then it's an adult patient. This is sleeping. Okay, the second part is the one is sleeping. This is the abdomen. See that one. This is another girl during sleeping. Flexion movement of the trunk. So what are these conditions? These myoclonus. sometimes occurring during sleep, sometimes otherwise it's occurring. These are proprioceptive myoclonus during sleep. It's best described as proprioceptive myoclonus, which involves involuntary repetitive jerks of the trunk and limbs that originate in the spinal cord. The specific subtype, that is proprioceptive myoclonus asleep proprioceptive myoclonus asleep onset occurs during the transition from wake to sleep, often worsening in the lying position, and can cause significant insomnia and sleep disruption. What exactly the cause is unknown, most of them idiopathic. This is similar to the sleep-related truncal myoclonus, usually presents as a brief involuntary contractions of axial muscles, causing sudden jerky movements of the body center. The latter videos which showed us only confined to the trunk, not spreading up and downward. These jerks may arise spontaneously or be triggered by external stimuli like sound and touch. In many cases, especially in children and healthy adolescents, they are benign, non-epileptic events that do not interrupt sleep and are not recalled upon in the waking. Sometimes similar appearing movements can be secondary to neurological disorders, may occur in association with sleep onset insomnia, excessive daytime sleepiness. This is something similar to the spinal segmental myoclonus, which can be either idiopathic or secondary to the lesions of the spinal cord. So that's a story. So today I've shown many involuntary movements affecting the eye and the limbs and the trunk.
Sir, in Eglon 5 disease, we also get this kind of sleep-related myoclonic movements, right, sir?
Yes. Yeah. Usually they get what you call finalistic movements. They what you call the daytime activities they enact during sleep. That's called finalistic movement during sleep. That's a classic in Eglon 5. But you can have associated myoclonus is well described. Chorea, myoclonus are all described in sleep. Someday they can have violent jerk also has been described during sleep.
Sir, apart from this spinal myoclonus, the cortical myoclonus may also persist in sleep, sir. Right, sir?
Yeah.
Some kind of cortical myoclonus.
Yeah, of course, definitely. Because that's originating in the cortex now. It's like it's equivalent to seizure phenomena. So just like can occur during sleep also.
But cortical myoclonus is generally in the distal parts of the limbs, not in the
Yeah.
trunk, so can be differentiated.
Yeah, that's correct. In distal part, asymmetrically present distal part of the limb. That's a cortical myoclonus. That is, previously they called this cortical myoclonus cortical tremor, confined to the upper limbs, distal part of the upper and lower limb. In the spinal cord, if it is okay, your trunk, you guys think of a proprioceptive myoclonus or a spinal segmental myoclonus.
Okay, sir.
One is spreading up and down, the other is confined only to one or two segments.
Sir, what's the treatment that you give?
Pardon?
What is the treatment that you give? Clonazepam?
Yeah, I gave clonazepam and sodium valproate.
Yes.
Okay, shall we stop?
Thank you, sir.
Thank you. Good night.
Thank you.
Good night,
night,
sir.
sir.
Thank you,
Thank
sir.
you. Thank you, sir. Good night.
Good night. Good night. Good night. See you next week.
Thank you, sir.
Yes.
Yes, sir.
Thank you. Thank you. Good night.